The Shockwave IVL uses intravascular acoustic pressure waves to fracture vascular calcium while preserving soft tissue integrity. Shockwave IVL works by delivering localized lithotripsy energy from a balloon-mounted emitter to break rigid vascular calcium, enabling predictable lumen expansion in lesions resistant to standard PCI techniques. The system, introduced clinically in 2016 and FDA approved for coronary use in 2021, converts electrical energy into focused acoustic pulses that target both superficial and deep calcium. Manufactured by Shockwave Medical in California, the technology is designed for heavily calcified coronary and peripheral diseases, including balloon uncrossable lesions, underexpanded stents, nodular calcium, and eccentric plaque patterns. The IVL generator console produces timed electrical discharges that travel through the catheter and energize lithotripsy emitters embedded along the semi-compliant balloon. Once the balloon is inflated to approximately 4 atm for apposition, each emitter vaporizes a small fluid pocket, generating a microbubble that collapses and produces a circumferential shockwave reaching roughly 50 atmospheres within the calcium layer. The balloon structure, proximal connectors, and safety-limited pulse architecture ensure consistent energy delivery, controlled expansion, and reduced perforation or dissection risk during plaque modification. The IVL catheter contains a series of evenly spaced lithotripsy emitters aligned longitudinally so that each pulse distributes circumferential mechanical stress across the calcium ring. During inflation, the semi-compliant balloon stabilizes vessel apposition while containing the saline medium required for bubble formation and wave propagation. Emitter spacing, balloon diameter selection, 2.5 to 4.0 millimeters for coronary devices, and the balloon's low-pressure compliance work together to deliver repeatable, vessel-safe calcium disruption with minimal barotrauma. Each electrical pulse instantly vaporizes a microvolume of saline, generating a rapidly expanding and collapsing bubble that produces a circumferential shockwave. These waves travel uniformly through the saline-filled balloon and couple directly into the vessel wall, where they preferentially propagate through stiff, high-density calcium rather than compliant soft tissue. Peak pressures near 50 atmospheres act for microseconds, producing controlled microfractures without thermal spread. Repeated pulses progressively decrease vessel rigidity by fracturing both superficial and deep calcium layers. The operator advances the balloon across the lesion over a standard guide wire, inflates to 4 atm for wall contact, and delivers lithotripsy pulses in cycles of 10, with up to 80 total pulses available per catheter. The balloon may be repositioned for long or segmented calcium, ensuring complete circumferential modification. After lithotripsy, the balloon is re-inflated to 6 atm for final expansion, and intravascular imaging such as OCT or IVUS verifies crack propagation, deep calcium disruption, and optimal luminal gain. Compared with RA, OA, excimer laser, and high-pressure balloon angioplasty, Shockwave IVL demonstrates superior calcium fracture efficiency, greater stent expansion symmetry, and improved safety through low-pressure operation. The circumferential shockwave mechanism avoids thermal injury and minimizes distal embolization while maintaining strong performance in severe, concentric, and nodular calcium patterns. IVL's ease of use and predictable energy distribution support its adoption as a frontline tool for complex calcified lesions. Fracture depth increases non-linearly with pulse count as cumulative acoustic energy progresses from superficial surface cracks to deep, multiplane calcium fractures across the plaque shelf. Early pulses 1 to 5 create initial microfractures, while intermediate counts 10 to 20 propagate cracks through deeper calcium layers. High pulse counts 40 to 80 generate widespread circumferential fracture networks that enhance vessel compliance and enable uniform balloon expansion. Shockwave IVL reliably modifies heavily calcified lesions, nodular calcium, and underexpanded stents with high procedural success and significantly reduced complications compared with high-pressure inflation or atherectomy. Clinical success rates average 92 to 95%, with OCT-confirmed stent expansion symmetry and less than 5% dissection rates. The technique's ability to generate predictable calcium fractures improves stent deployment, lowers restenosis risk, and provides a safe, reproducible option for patients with complex calcified coronary disease. Immediate survival exceeds 99% due to low-pressure inflation and minimal vessel trauma, while 1-year survival typically ranges from 92 to 96% with reduced early restenosis. 5-year survival ranges from 70 to 80%, reflecting durable luminal stability after optimized stent expansion. IVL adds only 10 to 20 minutes to procedure time and reduces dependence on high-pressure balloons or mechanical atherectomy, improving procedural efficiency and outcomes in severe calcification. The Shockwave IVL enhances coronary intervention by safely fracturing calcium, improving vessel compliance, and enabling durable stent expansion in complex calcified lesions.